Thanks, Imogen. I'd like to thank you for inviting me to speak. Sorry it's a bit of a rushed job, but I've got a few childcare issues at my house, so I've got to leave. I've got to leave straight away afterwards, although I think there's a bit of time for lunch. So it's a great honour to be here again after such a fantastic meeting last year. And Imogen's asked me to do a session. I think there's 40 minutes, right, Imogen? With some lunches at 12:30, though, so a bit less with time for questions, maybe? Okay, I'll see what I can do. Is there a clock anywhere? Oh, you've got the cards, have you? Okay. So what, there's a warning at 5 minutes? Or? Okay, great, yeah. Okay, so this is the title, From Chemotherapy to Targeted Therapy and Immunotherapy, what every patient needs to know. So I always like to show this slide as an introduction. It doesn't really actually just apply to melanoma. It could apply to lots of different types of cancer, solid tumours. And I suppose the idea is that there's been surgery and radiotherapy to treat cancer for quite a long time. In fact, people have probably done surgery to treat cancer for thousands of years. It's just I picked 1846 there because that's around about when general anaesthesia became available, which is obviously important for doing operations. And so radiation's been around for over 100 years now, but really it was at the end of the Second World War in the late 1940s that people started to develop drug treatment for cancers, particularly advanced cancers, and then so-called cytotoxic drugs. That just means drugs that kill cells, and it's kind of important, I suppose, because these drugs can be quite indiscriminate. In other words, they don't just necessarily kill cancer cells, but they can kill normal cells as well. And so that's part of the issue with those kinds of what you might call traditional chemotherapy drugs, but they're actually very, very effective to treat some types of cancer, particularly hematological malignancies, lymphomas, germ cell tumours. So these diseases, and childhood leukemia was really the real first example in the 40s and 50s, which was a disease that had been uniformly fatal with a number of weeks before these drugs came along. Actually, you were starting to see cures, a big deal. But for melanoma, to be blunt, and I'll come back to this afterwards, these drugs never really worked that well. Thank you, Imogen. And so what people were doing more recently towards the end of the 20th century was using cytokines, so drugs like interferon, interleukin, which are sort of non-specific stimulants of the immune system. And these drugs actually did sometimes work to control melanoma, although pretty rarely, and generally they're associated with quite a lot of side effects. And it wasn't really until the last 5 years, and I don't know if this projects well at the back, but what I've listed there is checkpoint inhibitors, so drugs like ipilimumab, nivolumab, pembrolizumab, targeted drugs, vemurafenib, trametinib, dabrafenib, cobimetinib, really came into use. And I think really it's just been in that last sort of 5 years or so that we've really seen drugs that can help a significant proportion of people who've got advanced melanoma with an acceptable level of side effects. So this is the sort of history slide. This is the AJCC staging system, or part of it anyway, for melanoma. Publication in 2009 in the Journal of Clinical Oncology. So I don't know if this pointer works, but for those who aren't used to this format, what these things in the bottom right-hand corner refer to are the journal and the year that these things were published, and the name is the first author, so they're usually fairly easy to search for on Google or PubMed if you're interested. Anyway, the point here, in the left-hand panel, you've got survival for people who've got stage 4 melanoma divided up by the organs involved effectively. So at the top, and that's the blue line, you have skin and lymph nodes. In the middle, and that's the sort of blackish line, you have lung, and then in the yellow line, you have yellow. And this is very large numbers of patients. So really, if you look at these curves, it tells you, with years along the bottom there, that actually the outcomes historically for advanced melanoma are really very poor, and the average life expectancy for people with advanced or stage 4 melanoma historically was between 6 and 9 months. And we've always known about LDH. I suspect, I know this is something that many, if not most patients are very aware of now, but we've always known that about LDH in this disease. We've always known it's a prognostic marker, meaning that if the LDH, which can be measured on a blood test, is high, then that means that statistically speaking, the outcomes are likely to be worse than if it's normal. And if you look on the right-hand side of the panel, you can see that the group of patients with the normal LDH are in blue. That's a blue dotted line. And below that is the patients who got a high LDH in the yellow line, meaning that your chances of survival, if you pick 2 years, are much less for the yellow line than the blue line. So that's kind of where we started from, I suppose, in this disease before the newer treatments came along. So I'm going to talk first of all about targeted therapies, and I'm going to say a bit about chemotherapy as well, because Imogen's asked me to. So the thing about targeted therapies is that melanoma is a disease that is characterized, actually perhaps more than any other type of cancer, by the presence of these abnormalities. They're called activating mutations. And this is a cartoon. And what you can see in these oval shapes, NRAS, BRAF, and so on and so forth, is the idea that there's things inside the cell, melanoma cell, the blue wavy line at the top is the surface of the cell. So there's abnormalities in these things, which you can think of, if you like, as sort of switches inside the cell, which are working in every cell in our body all the time, but they're vital for our cells to know what to do, to communicate with each other, to divide, to grow. And in a sense, what a mutation means is that something's gone wrong. And one way to think about it is the switch gets stuck in the on position, so the cells are growing and spreading and dividing when actually they shouldn't be. And the point, and now we're on the right-hand side of the slide, is that in melanoma, as I've said already, there's lots of different activating mutations, of which the commonest one is BRAF, which everyone's fairly familiar with. So about 40% of skin melanomas, cutaneous melanomas, will have these BRAF mutations. NRAS mutations are also pretty common, about 20%. And then KIT and GNAQ mutations are actually quite a lot rarer. And in fact, you only really get KIT mutations in mucosal melanomas, and about 20 or 30% of mucosal melanomas will have KIT mutations, and a few acral melanomas, which is melanomas on the palms and under the nails and soles of the feet. And eye melanomas, uveal melanomas, well over 80%, probably 90, maybe even 100%, will have mutations in this thing called GNAQ or GNA11. So well over half of melanomas, probably 2/3, 3/4, will have one of these mutations. And the reason this is important is because they can, in principle, at least be targeted with drugs. And I should say that all of this work I'm showing you here really comes from Boris Bastian and colleagues, and again the citations are at the bottom there, about 10 years ago now, who really laid the foundation for this understanding. So that's the background. Now, the story of targeted therapy, particularly BRAF targeted therapy in melanoma, in my opinion, starts here with this paper, which was actually published 15 years ago this month, so that's 2002, by a group of UK scientists from the Sanger Institute of Cancer Research, amongst other places, demonstrating that these mutations in the BRAF gene occur in human cancer. And actually, it's not just melanoma. There's lots of different types of cancer that have BRAF mutations, but they're commonest in melanoma. In other words, in other cancers, say colorectal cancer, maybe there's a 5 or 10% BRAF mutation rate, and you can get them rarely in lung cancer and thyroid cancer and things. But I've already shown you it's 40% in melanoma. So that was the scientific observation 15 years ago now. And that led eventually to this study here, now published in 2011, 6 years ago, where a drug targeting BRAF, vemurafenib, was compared with what at the time was the standard of care, which was traditional chemotherapy, which I've mentioned to you already. And again, I don't think the pointer's working very well, if at all, but in the top panel, and this is called a waterfall plot, what you can see is that the patients in this study treated with vemurafenib, and the dotted horizontal line is represents the fact that if you went into the trial and you treated with vemurafenib, below the line means there was tumour shrinkage, and above the line means that there was tumour growth. Same is true for the bottom panel, which shows chemotherapy. So you can see very clearly in the vemurafenib group, almost every patient in the trial had tumour shrinkage. There's a small group at the left-hand end that didn't. Whereas with chemotherapy, you can see that the vast majority of patients actually had tumour growth on treatment as their best response to treatment. But there was a group of people at the bottom right-hand corner who had tumour shrinkage with chemotherapy, which was dacarbazine or DTIC. So that's the first observation in terms of making a comparison between chemotherapy, which at the time nothing had been shown to be better, actually despite decades of research since the 1970s. I would argue, because we didn't really understand the biological basis of the disease for most of that time, but actually once we started to get a grip on the biology, and I've shown you the paper from 2002, then we had the basis for trying to actually rationally develop drugs. And then the response rate, and this is one way to measure the effectiveness of our treatments for vemurafenib. Now, this is a technical measurement response rate. You need to basically have over 30% tumour shrinkage. So although the vast majority of patients had some tumour shrinkage, 48%, which I hope you can read at the back, had this significant tumour shrinkage according to the RECIST system, whereas with chemo it was 5% at the bottom. Now, I'm going to say, I'm just going to show two other slides about chemotherapy, and it really is just for the record, basically. This is up to date now. So this is Checkmate, so-called Checkmate 37 study, which was a trial of nivolumab, an anti-PD-1 drug, versus investigator's choice chemotherapy, ICC at the bottom there, in people who had treatment with IPI already. So this is a trial that recruited around the world about 3-4 years ago now. And the point is, and this is called a swimmer's plot, and the horizontal bars, again, are individual patients on treatment, that you can see that there's only a really small group of people on the chemotherapy, there's 7, 8, 9, 10 bars there, who had tumour shrinkage, whereas lots of the patients on nivolumab had tumour shrinkage going out at the end of the graph to around about 3 years. This may not project tremendously well, but I'll tell you what it shows. And I think the key thing here in this trial is that the response rate, the significant tumour shrinkage rate for nivolumab in this trial was around about 30%, 30, okay? And for chemotherapy, it was actually closer to around about 10%, just over that, basically. So that is the difference in this randomised trial. People were allocated at random to these treatments. Nivolumab, about 30%, chemo, just over 10%, basically. And the other key observation, and I don't think people talk about this enough, is the length of response, measured by something called median duration of response. For nivolumab in this trial, it was 32 months, which is almost 3 years. And for chemo, it was just over 12 months, meaning if your tumour shrunk significantly and you had a response, if you're on nivolumab, that response was likely to last at least twice as long, almost 3 times as long, as if you're on chemo. So chemo can work. It's just not the first choice drug to treat this disease anymore. And it is still sometimes being used, and I'm sure that might be something for discussion, and we certainly use it in our practice. I hear people saying at meetings, we don't use chemo anymore to treat melanoma, and I don't understand that myself. I think there are situations in which it can actually be quite a valuable treatment. So that's my sort of 2 penneth worth on the subject. Getting back to this BRIM-3 randomised trial of dacarbazine versus vemurafenib. This is another way of measuring the success of a treatment. I'll look this way this time. And again, the pointer's not working very well. But the bottom line is dacarbazine. The top line is vemurafenib. And what progression-free survival means is from the start of treatment to the time at which the tumour progresses, defined technically. And so you can see, if you look at the dacarbazine line, at around about 6 weeks, there's almost a vertical line, meaning all the people who had scans at 6 weeks, which was the first scan in this study, who were on that part of the vertical line, the tumour progressed. Whereas you can see with the vemurafenib, yes, the tumours do progress, but it's clearly delayed by the treatment, basically. The difference between these two lines is measured by something called a hazard ratio. Again, that might be a little bit technical, but statistically, this was a highly statistically significant result. Okay. The average difference between the two curves, which we call the median, basically, so the average time for progression-free survival on dacarbazine was around about 6 weeks, and for vemurafenib in this study, it was 5.3 months. Now, we can all have views on whether we think that's a major difference or not. I mean, I sort of give this kind of talk to lots of different audiences, and there are different views on the value of that. But, I mean, I think most of us in this room at least would agree that that was certainly valuable and clearly indicated progress. And most importantly, perhaps, was on the background of rationally developing a treatment for this disease. It wasn't just, oh, let's try this. It's actually, we've got a drug. It targets BRAF mutant melanoma. We're going to treat BRAF mutant melanoma. So I think it's a big deal. More recently, just to sort of bring us up to date a little bit, and I'm sure lots of people in the room will know this already, a single-agent BRAF inhibitor like vemurafenib or dabrafenib has been superseded by the combination of a BRAF and a MEK inhibitor together. This is just one example. So this is vemurafenib, which I've just shown you. and the MEK inhibitor cobimetinib. I won't labour this too much. It's a similar type of curve, but you can see now the bottom line is vemurafenib, the red line, and then the top line is the two drugs together. Again, this is progression-free survival, and you can see very clearly with the eye, and statistics will demonstrate this is a highly statistically significant result. The averages in this study were around about 6 months for progression-free survival for vemurafenib, and then for the two drugs together, around about 10 months. So definitely an improvement. And there are now 3 randomized trials. Actually, this is just with vemurafenib, cobimetinib, dabrafenib, and trametinib. There is actually another combination of BRAF inhibitor and MEK inhibitor, which is on the cusp of being licensed at the moment. But the bottom line is that all these trials are pretty consistent, and the two drugs together is now standard of care for targeted therapy for BRAF mutant melanoma. And I'm pleased to say that NICE have approved, and again, I'm sure lots of people will know this, the combination of dabrafenib and trametinib. Vemurafenib and cobimetinib was not approved by NICE. Again, that's another subject, but that's where we are. Just getting away from these curves, which are very technical, to what this treatment can do. This is the youngest patient, actually, that we'd ever treated, as an adult oncologist with melanoma. It's a 17-year-old, and you can see this very nasty tumour on the right side of the neck involving the parotid gland. You can see the scar from previous surgery. And then this is a CT scan, and if you imagine you're sort of looking up into the body, looking into the skull, you can just see on the left-hand side there this very large lump on the side of the face. I don't think you need to be medically trained to spot the abnormality if you compare it with the other side, which is normal. And then you can see after 9 days of treatment, practically disappeared. So striking benefit. And my friend and colleague, Martin Gore, who I worked with at the Marsden, when this started happening a few years ago, he couldn't believe this. Martin's kind of at the end of his career now. He spent decades trying to develop good treatments for this disease, but it was really quite striking when we really first saw this. And reminiscent, actually, of treating diseases like lymphoma and leukemia, which I've mentioned to you already, which actually, with traditional chemotherapy, the tumour can melt away really very rapidly, just like this. And that was the scan, which again, the way to look at these scans is to compare the abnormal side with the normal side, or just compare from side to side. But you can see pretty much on this scan, that big lump I showed you before has almost disappeared after a very short interval of time. Okay, in the interest of time, I'm not going to talk about targeted therapy for KIT mutant melanoma. It's in itself a complicated subject, I'm afraid. I'm not going to talk about GNAQ, which really mainly just applies to eye melanomas. That in itself is a complex subject, and I think there'll be people talking about that later on. NRAS is targetable with drugs, but it's not straightforward. There has been a trial showing a benefit for a MEK inhibitor for NRAS mutant melanoma in comparison with chemotherapy. It wasn't compared with immunotherapy in this trial because at the time the trial was designed, the immunotherapy drugs hadn't quite come through. So there is some benefit there for a targeted drug. But in my opinion, at least, the benefit level is not that high. Certainly, it's nowhere near the kind of benefit level we see for targeted therapy in BRAF mutant melanoma. It may be that the drug is approved for use in the next little while, though. But again, in the interest of time, I'm going to skip that. So, challenges for targeted therapy. There is only one major challenge for targeted therapy, in my opinion, and it is this. I've shown you that dramatic response, which really is very valuable and very important, and a big breakthrough, as I've said already. But the problem with targeted therapy for almost every type of solid tumour, including melanoma, is that eventually most tumours will become resistant to it. Perhaps not all, but most, and I think that's an uncontroversial statement. So that's where the checkpoint inhibitors and immunotherapy come in, I think. So I've sort of shown you part of this already, but this is the idea that the drugs that had been used historically to treat melanoma and some other tumour types, including kidney cancer, interferon, interleukin-2, these are cytokines, and they stimulate the immune system non-specifically. Checkpoint inhibitors, targeted things like CTLA-4 and PT1 have the opposite effect. They're kind of negative regulators of the immune system. They take a break off the immune system. So that's just a very kind of simplistic way to think about it. The blue blob in the middle is a T cell, which is one of the immune cells. This is a T cell, again, in the middle. And it's just showing, actually, again, in a cartoon form, that CTLA-4 and PD-1, top right-hand corner here, the targets which are being attacked already, if you like, by drugs, monoclonal antibodies, I think are just the tip of the iceberg. So there are a range of other potential targets with these checkpoint inhibitors, and many of these are already in clinical trials at the moment. So certainly LAG-3, which is the bottom right-hand corner, the yellow one, we now have a trial at the Marsden, which is seeking to ask the question, do drugs attacking this work in people who haven't had responses to drugs like nivolumab and pembrolizumab? And then on the left-hand side of this cartoon of a T cell, there's a number of other potential targets. I'm not going to dwell on this at all, actually. I'm just wanting to make the point that actually CTLA-4 and PD-1 are just the first two of a lot of potential targets, and there's a massive amount of interest in this at the moment, not least from drug companies. So this is kind of maybe the most important slide of all, I think. This is the idea that treatment with an anti-CTLA-4 drug, ipilimumab or IPI, in comparison with chemo, dacarbazine, can result in what we call the tail on the curve. I think everyone's probably heard that expression by now. So the idea that there's a small group of people who are very long-term survivors, even with treatment with chemotherapy, but by having treatment with ipilimumab, which is what I'm showing here, there is this plateau in red between years 3 and 5. And if you just look at those curves, you can kind of see where the plateau starts. The yellow is the chemo, and then the blue is the IPI. And what I say to patients in clinic when we're having a conversation about treatment with IPI for advanced melanoma, or when I'm introducing the concept of treatment for advanced melanoma, is that treatment with IPI on its own has a roughly 1 in 5 chance in resulting in long-term survival, roughly 20%. And again, you could say, well, actually, is that worthwhile or not? But actually, it's clear that this was better than chemo. That's the important observation. And the other really important observation here is that most stage 4 metastatic solid tumours are not, in general terms, curable with the treatments that we have. So that's traditional chemotherapy and targeted drugs. And I think all of us in the melanoma world, clinicians, patients, everybody else really believes, and we have the patients in our clinics who can actually potentially be long-term survivors as a consequence of treatment with these newer immunotherapy drugs. The word cure is really difficult because the definition of cure, if you've got a metastatic tumour, a tumour that's spread, is actually to have a normal life expectancy and to die of something else after that normal life expectancy. And I would say we just haven't been using these drugs long enough to know whether that's going to happen or not. But the early signs are encouraging, I would say. So again, I like to show this slide. It's really worth looking this article up in The Guardian. You can find it in Google if you want to. This is all in the public domain. It's one of our patients. Sorry? Hands up? I hope you don't mind. Thanks for telling me, Imogen. But I love this article. You know that already, Sandra. I thought it was great. It was The Guardian's headline, and I think there is quite a lot of hype about immunotherapy in general, if I'm completely honest, and I'm not sure the stuff in the media is always that helpful when we're sitting down and we're discussing this in clinic, to be blunt. I don't know if I'm being recorded or not. I probably am, aren't I? Sorry. But I thought this was a great article, actually, and it's a great photo as well, if I might be so bold, Sandra. So I like to show this because I think, again, it just puts a human face on a lot of this technical stuff that I've been discussing. So anyway, I'm going to sort of finish off mainly. I know I haven't had the 10-minute thing yet, which is good, just by talking a little bit about a bit more about immunotherapy. So this is the Checkmate 67 trial, and it's a 3-arm trial basically, which was comparing IPI on its own, which at the time the trial was designed and recruited was the immunotherapy standard treatment, versus nivolumab on its own, so an anti-PD-1 drug. I think many people will be familiar with it. And for the record, I would regard nivolumab and pembrolizumab as indistinguishable treatments, okay, in terms of side effects and in terms of chance of success. The only difference is that pembrolizumab is given 3 weekly and nivolumab is given 2 weekly. I'm not going to say much about pembrolizumab, but I would truly regard them as indistinguishable. And those of you who know me will know that that's something I say to patients as well. Anyway, I'm just going to say that for the record so we're clear about that. The third arm of the trial was the combination of IPI and Nivo together, basically. And the way that works is that IPI and Nivo were given together for 4 infusions every 3 weeks for the first 12 weeks. And then after that bit, which I call the induction bit, nivolumab was given on its own, basically, for actually as long as the treatment was working and there weren't unacceptable side effects. So this is the design of the study. It was a randomized study. About 950 patients around the world went into it. Allocated at random, as I say, and also blinded, meaning importantly that no one knew, we didn't know, the patients didn't know, no one knew which arm of the trial that they were on. And we've still got patients, and there might even be some people in the room, we've still got patients who are still on this study now, and they're still having treatment, and we don't know what arm of the study that they're on, which is almost 4 years later we started doing this trial, or this trial was done, so it's 3-4 years later. So again, getting back to progression-free survival, which I've shown you a couple of graphs already. The green line is IPI on its own, so I think probably performing as I've shown you and as we may have expected. Clear improvement for nivolumab on its own, that's the blue line. And then the orange line, which is the 2 drugs together, a little bit better than nivolumab on its own for progression-free survival. But very, very importantly, this trial, for technical reasons, was not designed to compare nivolumab on its own with a combination of the 2 drugs together. That's a really important point. From a technical perspective, this trial was designed to compare nivolumab on its own with IPI on its own and the combination of the 2 drugs together with IPI on its own. Of course, what we're all interested in now is nivolumab versus the 2 drugs together, but when the trial was designed, that was not the question that was being asked. And again, I have to say that for the record, so we're really clear. Tumour shrinkage rates here might not project well, but for the combination of the 2 drugs together in the first column there, almost 60%, 60. For nivolumab alone, almost 45%. For IPI alone, just under 20%. And this business about median duration of response, I've said this already, but if you look at the bottom column, you'll see that for IPI alone, it was 18 months, okay? For nivolumab alone, it was 31 months. So that's really consistent with what I showed you from the other Checkmate trial, if you remember back to that. And then for the 2 drugs together, NR means not reached. In other words, the median duration of response hadn't been reached yet, despite just over 2 years of follow-up at the time these data were presented. Now, overall survival, and this is really the key thing which people are talking about a lot, and obviously the goal of our treatments is to prolong life expectancy. That's it's not about tumour shrinkage, although that's an important measurement. It's not about progression-free survival. It's about prolongation of life expectancy, obviously with acceptable side effects and good quality of life. And again, you can see here that the orange and blue are better than the green. In other words, both of the experimental arms are better, but the difference between the combo and nivolumab on its own, actually, there wasn't too much difference as a summary, but there was a difference, not statistically significant. The trial wasn't designed for the comparison, I'll say that again. But the what people call the landmark survival at 2 years, 24 months, which is the right-hand vertical line, you can see that for nivolumab on its own, the survival was 59%, meaning 59% of people treated with nivolumab on its own were still alive at 2 years in this trial. And for the 2 drugs together, it was 64%. And these data were just presented at the American Association for Cancer Research, which was in Washington in April this year. So it's reasonably hot off the press. What other treatment did people have after they'd had treatment in the trial? And you can see here that obviously once you've been in a trial and the treatment's no longer working, you would then have other treatment outside the trial. That's the natural expectation. So a lot of the people who had treatment with IPI then went on to have an anti-PD-1 agent. That's 42%. Again, I don't know how easy that is to see. A lot of the people who just had treatment with Nivo then went on to have treatment with IPI. That's about 26%. For the people who had the 2 drugs together, obviously, if the tumour had carried a BRAF mutation, then BRAF targeted therapy could be given afterwards, but less of those patients had actually had subsequent treatment. And the very bottom row actually shows you, and I think this might be an interesting measurement, actually, the number of people at 2 years who hadn't had further treatment for their melanoma for whatever reason. There'll be various reasons. So for IPI alone, it was only 25%. Who hadn't had further treatment. For Nivo, it was 53%, and for the 2 drugs together, it was 65%. So some differences there. This is called a waterfall plot, and really the reason for this is to try and detect if in any group of patients within the study there was more benefit for the combination versus Nivo alone. And the short answer to this, and you've got BRAF mutation, you've got performance status, you've got LDH, you've got PD-L1 expression, is that they didn't look like there were really any major differences. I won't labour this either. This is looking at BRAF mutant tumours versus BRAF wild type. BRAF is on the BRAF wild type, meaning no BRAF mutation is on the left, BRAF mutant is on the right. And again, I think it's the same sort of pattern that I've shown you already, basically. When the data were presented, a lot of people were saying, could there be a real difference there in the BRAF mutant group? And I personally don't think there is. I think it's sort of the same overall message. And when you do these kinds of subgroup analyses, you need to be very careful anyway about sort of reading too much into them and over-interpreting them. A lot of interest in PD-L1, and again, that might be a subject that comes up today and tomorrow in discussion. And actually, the tumours, this is using a 5% cutoff that had less than 5% PD-L1 expression. The combos seem to perform better than single-agent nivolumab, whereas it was pretty similar for the higher PD-L1 expressors, and this is overall survival. But if you look at tumour shrinkage rate, actually, even in the high PD-L1 group, where I've shown you that survival looked pretty similar, the tumour shrinkage rate for the combination in the high PD-L1 group was almost 75% versus 59% for one drug. And again, you saw that difference in the lower group. So that's, I think that's quite an interesting observation. And again, it's something that we think about in clinic. Side effects, I've just got this one slide. I think this has been talked about a lot, but we know that, and I say to patients, about 1 in 5 people treated with IPI on its own will have bad side effects necessitating hospitalisation, mainly diarrhoea and colitis. For nivolumab alone and pembrolizumab alone, for the record, most people do not have bad side effects. I would say about 90% of people don't have bad side effects. I think that's borne out here. Whereas for the two drugs together, I say to patients there's a 50-50 chance of having severe side effects requiring admission to hospital. And there were some deaths in this study, which you can see in the bottom row. So 1 or 2 actually in each arm of the study. Most people will know now that if there are bad side effects with treatment, we discontinue treatment, we stop treatment. And I think an important thing, and I say this to patients in the clinic, and I last had this conversation yesterday afternoon, that in people who stop the combination for side effects, and again, they're normally in the first 12 weeks, the tumour shrinkage rate in that situation is just over 70%. Okay, so lots of patients in my experience worry that if the treatment's being stopped, then it might compromise the chance of controlling the melanoma. But in our experience and in the literature, I would say that that is not the case. So just the last few slides. So how do we select targeted therapy versus immunotherapy for tumours with BRAF mutations? Well, there's lots of different issues to consider. We're talking about intravenous versus oral treatment, and so oral treatment is a lot more convenient, I would say, for most people, so that may be a significant consideration. The speed of onset of the treatment is a consideration sometimes as well. Where the melanoma is, I haven't talked about brain metastases, involvement of the brain. I'm sure other people will. That is certainly a very important consideration indeed. Side effects, the side effect profile of immunotherapy versus targeted therapy are pretty different. And of course, this is all a conversation, I would say, that we have in clinic when we're selecting treatment. Many people know this, but for the record, outside clinical trials, most of our patients will start treatment with immunotherapy, and then we tend to use BRAF targeted therapy afterwards. But that's by no means exclusive, and this is a discussion that we would have with patients in the clinic. The key issue actually here is we don't have evidence. So the real way to know the answer to this is to do a trial, and I've shown you loads of trial data where half the people get targeted therapy first and half get immunotherapy first, and they swap over. So I think those trials are ongoing at the moment, but at the moment we're having to use sort of clinical judgment in discussion, obviously with patients and their families, but I think, we need more data. I might just run over slightly, Imogen, but I've just got 2 slides on adjuvant because I think it's really important. I'm being allowed to run over. So adjuvant. So adjuvant, I always forget, is from the Latin or Greek to help. which means a treatment that helps the effect of another treatment. So in this case, it would be surgery. So the main treatment for stage 1, 2, and 3 melanoma is surgery. So in breast cancer and bowel cancer, decades of clinical trials have shown that having, in particular, drug treatment, chemotherapy, can statistically reduce the chance of the cancer coming back. And we've obviously been slower in melanoma because we've only recently, got treatments that can be potentially effective. So this is an important trial. And what happened in this trial, basically, is that people with stage 3 melanoma, so involving lymph nodes, are allocated at random to receive treatment with placebo, intravenous placebo, versus a high dose of IPI, 10 milligrams per kilogram of ipilimumab, actually for 3 years. It's a bit more complicated than that, but it's quite a tough treatment. And the red line here, which is placebo, the bottom line, again, this is overall survival, chances of being alive after the start of the study. The headline here for me is that if you're in the placebo group, the chance of being alive at 5 years was about 55%. And if you're in the IPI group, the chance of being alive at 5 years was 65%. So that is a 10% difference, okay, at the cost of considerable side effects with this dose of IPI. And there was a 1% death rate in this study. 5 people died in this study, mainly of colitis, but there were other things as well. This treatment is approved in the US by the FDA. It's not approved in Europe at the moment. It's actually outside the scope of me standing now on the podium to tell you my thoughts on this. When I talk to patients about this, and I talk to patients about this a lot, to have a proper discussion takes between half an hour and 45 minutes. It's a really complicated subject. One of the issues with adjuvant treatment, if you treat 100 people with adjuvant treatment, a lot of them will be cured already with surgery. And so you're giving potentially toxic treatment to people who actually don't need it. The next thing is that there might be some people who are destined to relapse from melanoma and they have the toxic treatment, it doesn't work, and they still relapse. So that hasn't been a success either. So the sweet spot for adjuvant treatment is people who are destined to relapse and the treatment works in stopping them relapse. And we have no way of knowing that at the moment, I'm afraid. So that's in a nutshell some of my thoughts. So to summarise, this disease really, I think, was regarded, certainly by oncologists historically, as untreatable with drugs once it had spread. That's true. No one could really believe when I started as a consultant 10 years ago, well, I'd want to do melanoma. I mean, seriously, that's true. People may have heard me saying that before. I think targeted therapy clearly is a major innovation for cancer therapeutics, not just in melanoma, in multiple different types of tumour. And critically, as I've said a few times now, based on understanding the biology of the disease, that's been the real driver here. Unfortunately, though, for targeted drugs, resistance is generally inevitable in stage 4 metastatic disease. On average, it's less than a year for most settings, including melanoma, where it develops. There's a few exceptions to that. Checkpoint inhibitors like nivolumab, pembrolizumab, IPI generally are well tolerated when given as single agents. The combination does have more toxicity, as I've said. And I haven't shown this, but it's true, and I'm sure everyone knows that it isn't just melanoma. These drugs are also active in multiple different types of cancer, and it's really, I think, we're in the beginning of a revolution with these new drugs as a treatment for cancer. I've shown you that anti-CTLA-4 therapy, IPI, probably is curative, and I've used the inverted commas deliberately, in a small group at the moment from what we think of people with advanced melanoma. I think we have seen a lot of progress in the last little while, but I think, most importantly, we've still got a lot of work to do, and I hope the last 5 years are just the beginning, and I would stress that we've made progress in this disease by doing clinical trials, and if we stop doing clinical trials, we will stop making progress. It's that simple. So we have to keep doing clinical trials. We have to do better. We have to develop more effective treatments. We have to develop safer treatments. We have to start thinking about quality of life. There's a lot of things that we still need to do, so we mustn't lose momentum now. So final slide. So I'd like to thank all of our patients and their families, I think many of whom are looking around in the room. So particularly people who've gone into clinical trials, it really takes a lot of bravery and commitment to do that. Our clinical trials team led by Kim Edmonds, one of our research nurses at the Marsden, my colleagues on the melanoma unit, Sam Matualic and Martin Gore. And I'd also like to thank actually there are too many collaborators, both in the UK and internationally, to name, in academia, in advocacy groups, and actually really importantly in industry as well. The drug industry gets a tough press sometimes, but a lot of this wouldn't have happened without them as well. So I'd like to make that clear. So thank you for your attention. And Imogen says there's some time for questions. Thank you.
Thank you, Dr. Larkin. That was very comprehensive and really interesting. I just wanted to ask you about the targeted therapy. You know, when patients have reached the tail of the curve, the longer surviving patients, I know it's a small percentage, but do you feel that there's ever any evidence to allow patients come off at that stage, or to maybe go on intermittent use? Is there reason to believe that there is a curative?
Yes, it's a great question. We have very limited evidence in this situation. What we do know is that for people who've had complete disappearance of the tumour, which we call complete response on scans, on targeted treatment, there have been situations in which treatment has been stopped. And in that situation, there is definitely a risk of the tumour regrowing. I think that's an uncontroversial statement. It's difficult to know what the chances are exactly, but the chances are not small based on my understanding of the situation. So broadly speaking, we would tend not to stop treatment even for people who've gone into complete response. But obviously, if there's side effects, you have no choice but to stop treatment. I think we need more data to understand this better. I think it's one of the key differences between targeted therapy and immunotherapy. With immunotherapy, you clearly can get prolonged benefit after stopping treatment in a pretty substantial group of people if they've responded. Then the other part of your question, which was about intermittent therapy, is absolutely wrapped up in this, because the question would be, if you stop treatment, the tumour grows and you restart treatment, can you recapture the response? I think often you can, is the answer to that. But I would say that intermittent therapy in this disease with targeted therapy remains experimental, critically speaking. And far as I'm aware, in most solid tumour types, there isn't great evidence for intermittent therapy, but there are some trials which are starting to start at the moment. I don't know if Pippa mentioned it, but if not, then I'm sure it will be mentioned. And I think it's a really important area. I treat kidney cancer half the time, and in kidney cancer there's actually been a large trial that's just coming to an end, where what's happened is that people have had the standard targeted drug, it's a randomised trial, half the people, and then the other half of people have been treated with the drug to maximum tumour shrinkage on scans. Then the drug is stopped. The tumour's watched with scans, so you have a pause from treatment, and then the treatment is reintroduced at such time as the tumour grows again. So that trial's just recruited in the UK, or it's just finishing recruitment, 800 or 900 patients. So at least in kidney cancer, it's a different disease, but in kidney cancer, we'll get some sort of answer in a good-sized trial to this question about intermittent therapy. But I would stress at the moment, I would regard it as being an experimental strategy and should be looked at properly in clinical trials.
Can you hear me?
Yes.
As a patient who had IPI in 2012 and survived 5 years so far, I'm coming to that point where my 6-monthly and then more latterly yearly scans have finished. And I just wanted generally from a patient's point of view, when those scans then stop, it's a very scary sort of situation, and you almost feel that you could relapse without anyone knowing about it, basically. I just wondered what your idea about the future is from then on. Yeah,
I completely agree. It is scary. I don't think we know, actually, what we should really be doing in terms of follow-up beyond 5 years. There isn't a large group of people in your situation, but it is a definite group of people. I think we need some research. We tend to follow up everyone pretty much in our clinic, at least, who's got melanoma that's spread annually, really for the rest of their lives, unless there's some other reason not to, like they've got other medical problems or they find it difficult coming to clinic. Scan frequency is quite difficult as well between years 5 and 10. I certainly think there probably is an argument for doing some scans between years 5 and 10, in principle at least, but I think it's an area where we need to get more evidence and get some research going as well. And the issues of or the question of the issues for long-term survivors from immunotherapy and melanoma. I think it's an almost completely unresearched area at the moment, and that's certainly something we're very interested in at the moment. I've actually had a few meetings recently about trying to get together a program to really try and think about what the issues are. And you can imagine, well, I don't need to tell you, but you know, there's the uncertainty, there's the anxieties, there's long-term side effects from immunotherapy. We know a bit about the short-term side effects, but the long-term side effects, so endocrine in particular, thyroid, pituitary. In younger patients, you've got issues about fertility and all these kinds of things. So, you know, I think we don't know is the short answer, and we need some research. I think that lady was next, sorry. Or does that mean one or two questions more? Imogen's telling me, so don't shoot me.
Quickie question, hopefully. In terms of the drugs that are being trialled at the moment for adjuvant therapy, the trials seem to be set up with a much higher dose than the treatment doses for, obviously, stage 4. What's the rationale for that, and is this something that's a pattern in terms of the other trials that may be being planned at the moment for stage 3 adjuvant?
Yeah, excellent question. I don't know if we've got anyone from BMS here. Hands up. Anyway, so when drugs are being developed, drug companies move incredibly rapidly, and they make decisions very early on in drug development based on relatively limited evidence. So the example really is IPI at a dose of 10 milligrams per kilogram. BMS took a decision relatively early on during the development of that drug to use that dose for adjuvant studies in melanoma. I suspect there was an idea that it probably had quite a lot more side effects than 3 milligrams per kilogram, but nevertheless that was their strategy. And then kind of the quote-unquote problem is that once that study is read out, it's been approved, it's been agreed with the regulators like the FDA and the EMA. Whether we like it or not, that becomes the standard treatment, basically. And so we're wedded to that. But just to expand slightly, we know in advanced disease that IPI-10 looks like it's got more benefit than IPI-3 at the cost of considerably more side effects. So there might be something there in terms of the chance of the treatment being successful, although I would be careful about extrapolating from metastatic to adjuvant, actually. And then just the final comment on adjuvant. There's now been a number of adjuvant trials that have recruited in the last 2 to 3 years, but a new adjuvant trial, some people probably know this already, is literally just about to open. Again, it's another BMS trial. It's opening in the next week or so for stage 3B, stage 3C, stage 4 NED, according to the AJCC 8 classification. Sorry for being technical, but I know lots of people in the room will be familiar with that. And it's IPI-10, that's the first arm. It's nivolumab as the second arm on its own. And it's nivolumab plus a small dose of IPI in the third arm of the study, asking the question, can you just have a small dose of IPI to try and get some of the benefit for the combination? So I actually think that's a smart study. If people are interested in that, by all means, drop me an email. You need to get into the study, you need to have had surgery for stage 3 disease within the previous 13 weeks. That's the key issue, basically. So it's really for people who are just going through that at the moment. One more question, Imogen, yeah. I don't want to get into a fight about who's next. I was going to probably stay for lunch, so... Okay, Imogen said that.
You mentioned whether you give targeted drugs or immunotherapy first, or vice versa, and you said there was trials for that. If you've had targeted drugs and then you've had immunotherapy drugs, the next part's sort of 2 points. Can you go back to the targeted drugs, and is it any evidence that they would work the second time round?
Yeah, if I do that the other way round, if I may, there's definite evidence that BRAF targeted drugs can work in that type of situation. The benefit level, if you're having them what we would call third line, seems to be quite less than if they'd been in the first line situation, but there can be some benefit certainly, and there's some reasonable evidence for that now. To some extent we've known that for a while actually, anecdotally, but there's now some sort of more solid evidence for that. Broadly speaking, that is not reimbursed by the National Health Service though, I'm afraid, and so although you might get some benefit, I'm afraid there isn't anyone on the National Health Service that at the moment would be prepared to pay for that, and they would probably say if you asked that the evidence level wasn't high enough. In other words, they'd want a randomised trial to demonstrate demonstrate benefit. But I would say that typically speaking, the amount of benefit, let's say dabrafenib and trametinib might work for 12 months on average first of all, then immunotherapy, and then you go back to dabrafenib and trametinib. Broadly speaking, I think it would probably work for 4 to 6 months on average. So, I mean, I wouldn't want anyone to think that it's, you know, it's a massive amount of benefit, but I think it can have definite benefit. And these are very expensive drugs. I think everyone knows that. Imogen.
Thank you, James. We are running